this month's journal cup was CP journal cup. Mentor is Dr. Durida. Dr. Durida put this article in the email, welcome Western to take it for CP journal cup. So it's about sickle cell disease treatment using red blood cell exchange, as we know, but they include a new parameter, at least new to me. We call it a daily rate of rise in hemoglobin X. Let's go through sickle cell disease first briefly. I think everyone is familiar with that. This is sickle cell disease. It's most common hemoglobin nephropathy in the United States and characterized by abnormal hemoglobin S. And from this image, we know the cell gets sickle in the hypoxia environment, and then it can get clot, hemolysis, and also cause steroid inflammation, and then cause all kinds of this complication. As we know, sickle cell disease, if they have these three complications, we need to do emergency red blood cell exchange in our CP practice. Acute chest syndrome, stroke, /TIA, and hepatic sequestration. And usually sickle cell disease, if they do not have any complication, they just use a simple red blood cell transfusion to maintain their hemoglobin level. But if they have different kind of complication, then we need to treat them according prophylactic because we try to prevent this kind of complication. So using red blood cell exchange. And then we have our goal. I think different institutions may use different goal. I think in our Geisinger, usually we set up hemoglobin as less than 30%. And but how many units do we use? We have a basic calculation, but everything just based on the experience. So we do not have really objective thing to estimate. And in this normal situation, we can usually patient will send for the hemoglobin electrophoresis to know the hemoglobin S level in the patient. But in this emergency situation, there's no way to wait for that. So this paper just would like to introduce this ROR daily rate of rise hemoglobin S to kind of predict the hemoglobin S level in the patient. So we're all familiar with two mutations in the HBB gene. Then hemoglobin S polymerization causes sickle of the red blood cell and the hemolysis in inflammation. I already mentioned the current treatment is we can use hydroxyurea to increase hemoglobin F level and trying to more stabilize of the hemoglobin. And also we can use the simple red blood cell transfusion to maintain the hemoglobin. And then if we do red blood cell exchange, is the target usually use pre-procedure hemoglobin S level less than 30%, and the hematocrit level after the procedure is 30%. But sometimes patients we may increase a little bit for the hematocrit because one of the hypotheses is that if we increase the hemoglobin level, hematocrit higher, it can depress suppression of the erythropoiesis. So just cool down the marrow, not make them crazy, because if the marrow going crazy for the hematopoiesis, they will produce more hemoglobin X. That's something we don't want. So sometimes we will increase hematocrit level. But as I mentioned, the clinical trial for red blood cell exchange is that I think just based on the experience, we do not have really objective parameter to predict it unless we do the hemoglobin electrophoresis. So the goal of this study is to evaluate the utility of daily rate of rise in hemoglobin S for managing red blood cell exchange treatment. So the method, they include 24 patients. This is a single center study, 660 procedure. And then all the procedure they did they choose the interval between 42 days, because if the treatment interval is longer than that, this ROR level may decrease. So they want to have more stable, so they just choose this interval. And then age range of all the patients from pediatric 4 years old to the 59 years old. And they do retrospective chart review, and then they include all of these parameters. And then this is the calculation for this ROR, procedure hemoglobin as percentage minus prior post-procedure hemoglobin as percentage divided by interval in days. And they include two parameters to evaluate. That's the post-procedure hematocrit. The other one is hydroxyurea, because these two theoretically may have some impact on this ROR level. First here they show us this is the number of the patient, and then the left side is the pediatric group, the right side is the adult group. They divided also female and male, but you can see when you compare different patients, they have really high variation of this hemoglobin ROR percentage. Some patients are really low, 0.25, and then some patients can more than 1. But if you see just individual patient, this error, they use standard error, so it's kind of tight. So for one individual patient, it's kind of stable. So we could not use the same standard to evaluate for the all patients. But if we already have the clinical data to calculate this ROR level for one patient itself, it should be stable. Then, as I mentioned previously, we have the hypothesis that if we have higher hematocrit level, we may decrease the hematopoiesis, and then we may produce less hemoglobin S every day. But from this study, it seems not. And then even worse than that, if they even can see this positive correlation, but the R square is really small. So it's just a trend. So, and then they have some explanation is that usually if the patient had more severe sickle cell disease, we may try to increase the hematocrit level for this patient. So that's the reason if the patient have more severe disease, we can estimate that hemoglobin S increase daily will be higher. So, and then this patient may, our target hematocrit level may be higher. So this is one of the explanations for this real finding. And then also in the individual patient, whether you set up a target just at 30% or more than 30% of hematocrit, it seems most of the patient no significant difference. So it seems our hypothesis is not really correct, because no significant difference for the daily raise of hemoglobin S level. Just one patient, they can see this trend, but the rest of the patient, it didn't show anything. Then another impact factor is the hydroxyurea, because we know hydroxyurea can increase hemoglobin F level. So again, they show the same thing, whether you use hydroxyurea or no hydroxyurea, R square are still really small. They do not correlate with hemoglobin S rate every day. And then even for urea, if one patient, if you don't use hydroxyurea, this patient has decreased this hemoglobin S rise percentage. And here they just select some patient to show the representative paragraphs show from their age group 7 to 11. Over this 5 year, the ROR level is quite stable. So they did not change a lot, even from this 5 years interval. They also show, even in pediatric patient or adult patient, the first 5 ROR level and then the last 5, they compare that. It seems most of the patients still stable. So it didn't change by how many procedures you did. So, and then they use this equation to calculate this predicted hemoglobin as percentage. So they use rate ROR hemoglobin S multiplied by the procedure interval and previous post-procedure hemoglobin S percentage. And then they can get this positive correlation, even though R squared is not too good, but still good enough to predict hemoglobin S level and observer hemoglobin S level by our hemoglobin electrophoresis. And then I highlight this because if we know this hemoglobin S predict, and then we can reverse know how long the patient need procedure. So the key finding is that this ROR level in sickle cell disease patient is consistent within individual. So the variation within the same patient, they are very small, pretty stable. They don't even, they are not even influenced by procedure, hematocrit targets, or medication use. Especially for this study, they use hydroxyurea. Then we may have these three applications for this ROR. First, as I mentioned, if we know our target hemoglobin S percentage, and then we can use this equation to calculate how often do we need to do this red blood cell exchange in patient. Because right now we just based on our experience, so we do not have anything objective to show how often patient need to go to the apheresis clinic. And then also help in early stage therapy adjustment, especially when the patient they have some other life family issue or maybe some other health issue, and then they just miss some of the red blood cell exchange, and then we can use this predict level to just guide the patient when they come back and then do the red blood cell exchange. And then, of course, as I mentioned, for the emergency situation, we do not have time to wait for the hemoglobin electrophoresis for the true HBS percentage, but we can use this equation calculate, and then we have the predict hemoglobin S level. But also the limitation of this study is this is a retrospective study. Then they also have limited patient in a single study, so we need multi-center study to see whether this parameter is as good as this set. Thank you for your attention and